All right. Anytime you're ready, the floor is yours.
Okay. All right. This is a 31-year-old male that I met several months ago. He was diagnosed with Hep C while incarcerated in Salem, Virginia. And he gives a history of starting to snort different drugs at age 17. And he used IV drugs between the years of 23 and 29 years old. He stopped altogether when he was 29. And he said that he had sexual relations with a Hep C positive person, and he had also shared personal items with that person. He has multiple tattoos, and at least half were non-professional. And he had been in prison 3 times for a total of 10 years, and he also had tattoos while in prison. He's not in MAT, but he goes to counseling now, and he has not used any drugs for over a year. He really did not know at what point he got Hep C. He does have other comorbidities, and those you can see: asthma, BPH, a history of HSV. He has bipolar disorder and depression, PTSD, and agoraphobia that is fairly well controlled. He is a smoker, and he is somewhat overweight, and he had a vitamin D deficiency. The bipolar disorder is controlled with the lithium. His asthma at this point is well controlled. And there are the rest of his meds. So he is, he started on his Hep A and Hep B, and he's immune to both at this point. And there you can see he weighs 216 with a BMI of 31. So here are his labs. And the CBC was basically normal. Liver enzymes were normal. So the APRI was 0.393 with a CTP of 5 and a MELD score of 7. Those are his iron studies. And he was a genotype 2, and his viral load there is over 10 million. We did the FiberSure, and his biomarker was 0.07. He was scheduled for an ultrasound and missed the first appointment, and his second appointment is scheduled for the 18th of this month. He is on a PPI, and we have one random UDS that he will be coming back in next month to get another UDS. And I put on the, as far as the medication, to avoid Harvoni, but that's not a treatment for genotype 2. Harvoni and Zepatier would not qualify, and so I was thinking either Mavorite or Epclusa would be something he could take. Especially, he's on a PPI, and so he could take that with Mavorite. So I'm open to suggestions.
That was excellent. Thank you so much, Tammy. Any thoughts, comments, recommendations for Tammy and her case?
Mitra, do you want me to go?
Absolutely, that would be great. Thank you.
Tammy, this is John Gilhus. Start out by just complimenting you. Very advanced user, wonderfully done. I don't think I can tell you anything you don't already know. You did beautifully, truly so. To get to the punchline of therapeutics, I would go probably with Mavorite on him, simply because of the higher dose of omeprazole that he's taking. Remember, Epclusa sort of maxes out at a omeprazole dosage of 20 milligrams a day, and then there's a tricky co-administration instructions where you'd have to take the Epclusa 4 hours before the omeprazole. So that sounds complicated. It's hard for me to remember, and I'm sure it'd be hard for patient to carry out. So the Mavorite will not have any similar restrictions. Remember, it's going to be 3 tablets once a day with food for a shorter duration as well. So whereas Epclusa would be 12 weeks for all genotypes and all levels of cirrhosis, this will be 8 weeks for Mavorite. I think for him it might be the simpler one. You know, big picture, this guy's got interesting risk factors. Boy, he's got almost all of them. You know, and professional tattoos, the snorting, the sexual partners, and all that stuff. He ended up getting a really unusual genotype 2B. He's got a really impressive viral load. Remember, in terms of the genotypes, that's not one of the ones that has higher rates of fibrosis than expected. So it's the genotype 3s that tend to progress more rapidly towards fibrosis, or genotype 2s are actually, and Dr. Feinberg can speak to this as well, these used to be the ones we celebrate, because even in the interferon era, they responded really well. These were 90+% cures even with interferon days. And moving forward towards the direct-acting antiviral era, they've not really been terribly hard to treat, unlike the genotype 3s that have always have become more challenging, and not only from rates of progression, but also a little bit more challenging to have really outstanding SVR rates. Now that's sort of changing recently. Now, in terms of his extrahepatic manifestations, I'm not going to steal, you wonder if won't be improved, and there's nothing wrong with suggesting that possibility. You know, humans are suggestible creatures, so hopefully telling him he very well may feel better with getting this Hep C virus out of his body. But now he has early fibrosis or no fibrosis, actually, significant fibrosis measured by APRI or FibroSure. And so this lets us know that after his SVR is obtained, after his cure is obtained 3 months after treatment, he will not need any long-term follow-up. So he won't need HCC screening. He won't need anything else. He'll kind of be, it should be behind him. The major part to educate him on is risk of reinfection will obviously be real. Yeah, it'd be fascinating if his a sexual partner is someone who is your patient, to wonder if they also had genotype 2, because it would be interesting to know. You know, sexual transmission from a female to male is fairly infrequent. We really talk about MSM, so men who have sex with men, with the transmission, especially in the setting of HIV, it being a little more pronounced, or man to woman. But of course, it can go either way. Mm-hmm. But Tammy, my compliments. You did great. I think I'd go with Mavorite in the no hesitations that I can think of.
Okay.
Yeah, I agree with that. But just a couple of questions and a comment, Tammy. He started snorting drugs at 17. What did he snort? Do you know?
I'm not sure.
Because if it was cocaine, that might be his route of infection, right? From nasal bleeding and sharing, straws or implements with other people. And he was incarcerated in Virginia. Where did we get the Virginia part from? Or only West Virginia?
Well, Well, I wondered about that because there is a segment in West Virginia. But that was just from researching his chart.
Okay. I don't know why I thought Virginia. I might have hallucinated that. But, West Virginia is rather unusual in that we have a fair amount of genotype 2 and 3, probably together accounting for about a third of our Hep C. And, I moved here from Ohio, and the only people I ever saw non-genotype 1 in were like patients I had who had skipped out on their student visas from the former Soviet Union. So, in other parts of the country, it's all genotype. West Virginia is kind of unusual, but it's really always something to keep in mind because John's quite right. 3 used to be that genotype 1 was the one we feared and was worried about. Yeah, I hear you, Carmen. I hear the extra noise too. I don't know where it's coming from. But, in the current era, 1 is easy to vanquish with the drugs that we have. And it's really interesting. It's really turned the tables on 2 and 3. And yes, it is better now. Whatever the adventitious noise was, Mithra, whatever you did, it fixed it. Maybe you muted everything. But I agree. I think Maveret, I totally agree with John. When I start thinking about explaining to patients complex dosing schedules, like take this in this order and there's so many hours before this or that, I always stop and think, could I do that? And usually the answer is no. And if I can't do it, why should I expect anyone else to do it? And so I think the better part of valor is always to make things as straightforward for people as you can. At any rate, at his higher dose of omeprazole, that really kind of knocks Epclusa out anyway. But even if he was on 20, then you would still have to go through this rigmarole of taking the drugs with respect to, the timing of the drugs with respect to one another. And you know what? It's just harder than it's worth, right? So I think John's totally right. Make it easy for him.
Okay, thank you.
Thank you all for those recommendations and feedback. Were there any other questions about the case? Anyone out there in the community as well? Anything similar you've seen out there?
Tammy, we never talk about vitamin D levels to replete to, but probably you want to shoot for 40 to 50 in that guy. Get him back up at a good level.
Okay. Thank you.
And you're right, you can sort of accelerate that by giving him a high dose weekly for, I forgot what his level was. What was his level, John?
It was pretty terrible. I think it was like 17 or something.
Yeah, that's bad.
Yeah, it was.
I would give him high dose repletion, like, 50,000 units for a week for 8 or 12 weeks, and then go to somewhere between 2,000 and 5,000 a day. And, I would aim at least for around 50. You want to, turns out to be a very important part of the immune response. I think something that we really didn't recognize even 5-10 years ago, but that we're very conscious of now. And I think part of the consciousness came through our work with HIV. And, it really turns out to be an important aspect of the immune system to have adequate vitamin D levels. So, since these chronic viral illnesses really, take a major hit on the immune system, you really want to bolster people and keep them up there.
Okay, that's helpful. Thanks.
The high dose is prescription. The other doses are like over the counter. But, you should tell him to look on the internet or, go to a discount place like this. You don't want to buy your vitamin D at the General Nutrition Center where they'll charge you 10 times more than it really costs. Vitamin D should be really inexpensive. Like, I don't know, the equivalent of a couple of cents a pill. And you should be able to get a year's supply for like $10. which you can do.
And I apologize, I misspoke. The vitamin D is 22, but I think the advice stands sound. I misread the AFB, which is below it, which is 1.7. My old eyes read it as 17. So
And that's okay. 22 is not a whole lot better than 17.
not any better.
Yeah.
Not any better. The same advice would hold.
All right, thanks.
That's excellent. Thanks, everyone. Were there any other comments or questions before we move on to the didactic portion? Tammy, was there anything else you'd like covered with the case?
I think so. I appreciate the comments.
Absolutely. All right. Well, thank you so much for that case. That was excellent. And thank you all for that feedback as well. So let's go on to the didactic portion now. Dr. Feinberg, I can pull up your PowerPoint for you and just let me know when to advance the slides, and I'll do that.
And John, chime in, and we'll do this.
Absolutely. Sounds good.
You always have good things to add. Okay, I'm going to talk about the extrahepatic manifestations of Hep C, which are from the ridiculous to the sublime, right? From things that are just minor and irritating, but to things that, cause significant morbidity and mortality. So next slide, Mithra. So chronic Hep C, classically, people have fatigue and they complain that their joints and their muscles ache. And they also have malaise. And really, a significant proportion of people, feel depressed and feel like I have it described to me as like brain fog, like they're just not as sharp as they should be. And in fact, a lot of times people recognize these problems after they've been treated, and they come back in and they say, "Doc, I didn't realize how depressed I was, how tired I was, like how foggy my brain was." So sometimes they don't tell you this up front. You learn it after you have fixed it. Next slide. So we think that overall this occurs at a significant minority of our patients, maybe 40%, but we really don't know. The true prevalence is not known. That when you look in the literature, the estimates are very variable. And there's a number of different mechanisms that cause these associated problems. Some of it is direct tissue damage from the virus itself. Sometimes it's a result of the systemic immune response. Insulin resistance plays a role in some of this. And most of the extrahepatic manifestations, we manage by treating the underlying hepatitis C. And I'll point out when things require their own specific treatment. Next slide, please. So really, as I said, from the ridiculous to the sublime, this almost a body system, probably almost not a body system that isn't affected by hepatitis C. And some things are rare, like uveitis, and some things are really common. And we'll go through this kind of system by system. Next slide. So here's kind of a picture, right? And it gives you sort of the same summary as the previous slide, but it's more visual. And, as I said, we'll see some of these things are cause significant morbidity on their own. Next slide. And you'll get all these slides. So the endocrine system is one of the ones that is can be seriously affected by hepatitis C, right? Insulin resistance is a part of the picture, and insulin resistance to the point of developing frank diabetes. There's hyper and hypothyroidism. There is the development of thyroid antibodies. And there's Hashimoto's disease, which I have not seen, but, is said to exist. So, usually the most compelling problem one tends to see among endocrine disorders is diabetes, which you, of course, have to treat as if it's diabetes. And the same thing with the thyroid disease. You have to, people are hypothyroid, they need thyroid replacement. In general, even these manifestations will improve with Hep C cure, but they may not vanish. Next slide. So insulin resistance is pretty common, right? Somewhere between a third to almost a little over 2/3 of the patients. And standard type 2 diabetes, you can see in up to a half. And metabolic syndrome, for which, insulin resistance is part and parcel, is also pretty common. And we think this has got to do with destruction of pancreatic cells, either directly by the Hep C itself or indirectly because the immune system gets a little hyper in responding to the Hep C. As I said in the last slide, if you cure the Hep C, you may lower the risk of diabetes or make it less severe. And of course, weight loss, exercise, and if needed, medications for diabetes are all a part of the appropriate management. Next slide. There's a mild sialidinitis in up to a quarter of the patients. And maybe half the patients have lacrimal dysfunction without having dry eyes. I don't know how you actually determine that, because the only thing I would ever test a patient for lacrimal dysfunction is the complaint of dry eyes. We used to use this little, I don't know if anybody does that anymore, John. We used to use those little like blotter paper strips to see, over time to collect tears to see if people are actually making enough tears. Mostly, I think now people say they have dry eyes. You say, okay, well, use like methyl cellulose eye drops. Next slide. So here's another organ system that can be really dinged by the extrahepatic problems from Hep C. You can see mild to moderate proteinuria in up to about a quarter of the patients who have microscopic hematuria. Glomerular deposition of immunoglobulins and complement have been reported in a cryoprecipitate that also contains Hep C RNA and anti-Hep C antibodies. So it's clear that this is being triggered by the Hep C itself. And membranoproliferative GN has been reported, which you diagnose by renal biopsy. And once again, if we successfully treat the Hep C, typically that really helps improve renal function. Next slide. So mixed cryoglobulinemia is relatively common. I think one of the most fearful consequences of hepatitis C is non-Hodgkin B-cell lymphoma. And again, the risk is lowered by curing the Hep C. Lymphoma, NHL, tends to occur in all kinds of groups of patients who have sort of a chronic immune issues, right? It's a AIDS-defining illness in people with advanced HIV disease. You see lymphomas in people who are chronically immunosuppressed for organ transplantation, right? You see them in people who have kidney transplants, et cetera. So here's yet another circumstance where you can actually develop a lymphoma. And while treatment lowers the risk, it doesn't obliterate the risk. And then, if people develop NHL, of course, they have to be treated specifically for that. Next slide. What happens with this cryoglobulinemia is that you see that you get precipitates in many organs that are immunoglobulins complexed with hepatitis C particles. And you see this in the kidneys, as we just described, but you can see this in the skin. And you'll see in subsequent slides. Oh, I forgot. I wonder if I put the pictures in this slide set. I hope I did. There's a lot of different dermatologic problems with Hep C. And also you can see this in peripheral nerve fibers, so that, you can really wind up having peripheral nerve dysfunction as a result. There are specific ways that the blood specimens have to be handled when you are looking for cryoglobulins, and if the blood specimens aren't managed right, you won't get the result that you're looking for. And cryoglobulinemia seems to be relatively common in people who have fairly advanced fibrosis. And, again, if you treat the Hep C, you may improve the vasculitis that's part of this. Next slide. Here's the non-Hodgkin lymphoma slide. So we can find Hep C RNA in lymphoid and bone marrow cells, even though really the primary infected cell is the hepatocyte. And a little more than a third of the patients with B-cell lymphomas and almost 90% of the patients with non-Hodgkin lymphoma and cryoglobulins have reported Hep C viremia. So sometimes, B-cell lymphomas, right? What are the primary complaints for lymphoma? Fatigue, sometimes fever, it's kind of vague. And sometimes the vague symptomatology can be ascribed to the Hep C itself. And you just have to sort of keep an open mind and be aware that this can happen so that it doesn't wind up getting overlooked. Next slide. So rheumatoid arthritis-like symptoms have been pretty commonly described. And when I say RA-like symptoms, symptoms that are predominantly stiffness in the morning and symmetrical arthritis of the small joints. So typically the arthritis is less severe than RA, but I have taken care of patients whose fingers were so swollen they looked like sausages. They were practically stuck together and red and hot and really uncomfortable. So this can really be quite a significant complaint, and really cause, a struggle with just doing, the routines of daily life. You don't get the chronic deformities that you get with RA, but as I said, the discomfort from the inflammation, can be really impressive. Medium and large joints are not affected as commonly, although the ankles are probably the most common site for the larger joints. And the majority of the patients who have arthritic-like symptoms will also really complain of significant fatigue. Next slide. So I don't know if you can perceive it in this picture, but these hands and these fingers are swollen. There's other ditzels on the hands that were not part of this point. Next slide. Neuropathy has been seen in somewhere between 11 and 30%, including peripheral neuropathy, although that's uncommon. Really, the most common complaints are muscle weakness. And you see this a lot in people who also really complain of fatigue, and often accompanies the cryoglobulinemia. Next slide. So there are just a ton of dermatologic syndromes that can occur with Hep C. There's non-specific stuff like, chronic itching, pruritus, but you can see palpable purpura in up to a third of the patients. When people have cryoglobulins, you can see what the dermatologists call necrotizing leukocytoplastic vasculitis. And these are usually most obvious on the lower extremities. You see a whole range of manifestations. You see petechiae, you get the palpable purpura, you see nodules, you see ulcers. I'll show you a couple of pictures. And then you can see lichen planus in the mouth, E. multiforme, E. nodosum. People can have urticaria. Porphyria cutanea tarda has been described with Hep C. And I think if you go to the next slide, here's the lichen planus. This also can see on the hands as those whitish patches. Next slide. This is the kind of the severe manifestations you tend to see on the lower extremities. So this is a woman with, I don't know if you can sort of perceive that there's a roughness to the surface of her skin, but these are a lot of palpable purpura that are due to the necrotizing vasculitis. Next slide. So just to summarize, the liver and the hepatocyte really is the primary target for Hep C, but it is a systemic disease and really can involve multiple organ systems. And you really have to be conscious of the multisystemic nature of Hep C, because it can have significant effects on patients' well-being and the quality of life. As I said, some of these things are annoying. Like, it's not fun to itch all the time, but it's beyond not fun to get lymphoma, right? And luckily for us and our patients, many of the manifestations of extrahepatic Hep C either resolve entirely or certainly improve with the achievement of an SVR12, but not all. Risks can be lessened, but cannot be removed entirely. And, some of these diagnoses clearly are going to require specific treatment of their own. I think that's the last slide. It is. I'm happy to take some questions. I'm actually eager to hear from John what he wants to add to that.
Dr. Feinberg, thank you. This is John. That was beautiful. Very, very well done. Obviously, I had said a couple quick things to supplement and to 100% emphasize what Dr. Feinberg said in her closing slide. Look for these extrahepatic manifestations, and if you look for them, you'll find them. But they're really easy to miss. Otherwise, I wish that hepatitis C was not named hepatitis C. If I could go back and rename hepatitis C, I would choose a very unpopular name. I would call it chronic systemic RNA flavivirus with a predilection for hepatic fibrosis. And I'm kidding, of course, but that's really what it is. It's a chronic systemic flavivirus, and it gets named after the one organ that gets hit more often and more severely. But all these extrahepatic manifestations matter a ton, especially for patients' quality of life. The only things I was going to mention otherwise is the response to therapy can definitely require patience, both from us as providers and for the patient to expect that these might go away super quickly. As a lot of them are not just viral mediated, they have some component of immune stimulation. It can take time after the virus is gone for a patient to start feeling better. So preaching patience to them after their SVR is obtained. We used to look at these extrahepatic manifestations more often under the context of trying to come up with non-fibrosis related reasons people would qualify for therapy.
Right.
Back in the day, before last year, we had all these fibrosis restrictions, so we would try to come up with any other urgent need for a patient to be treated. But that doesn't mean that they become less important just because we no longer have those fibrosis restrictions. And then the only last thing I want to mention is that particularly tricky joint complaints that rheumatoid arthritis-like manifestations of Hep C is a real conundrum, because it can even be rheumatoid factor positive. And I've absolutely seen people come in with a diagnosis of rheumatoid arthritis, even on immunosuppressants from good rheumatologists. But at some point, they should always get Hep C and Hep B serologies, just to make sure that this is truly, truly RA and not a hepatitis C induced RA mimic. So remember that, the rheumatoid factor positive, CCP negative.
Yeah, that is a really important point. I should add that to my slides, John. I always forget to add that, because you can see rheumatoid factor in many infections and inflammatory states. It's not specific for rheumatoid arthritis. And I have actually seen the same thing, John. I've had patients be referred to me who's RA, who have actually been diagnosed and treated as if they have RA, but what they really have is chronic Hep C. And it is really true that you have to be patient for the extrahepatic stuff to wane. Because think about it, I've described to you that pathologically this cryoprecipitates, there's chunks of stuff in people's organs that are the combination of immunoglobulins and, Hep C particles. And that stuff isn't just going to, vanish in the breeze. That stuff, it, really does take time for the immune system to heal and for those manifestations to subside. If you're patient, they mostly do, or they get a lot better. I would say that. And the patient who had like red hot sausage fingers, that never went away entirely till she got a liver transplant, which she eventually needed. But she had had Hep C for so long. But it did get a lot better with Hep C treatment, so she could actually flex her fingers again, and they weren't just sausages. And she was miserable. I mean, she was far more miserable from her arthritis than from her AIDS, her Hep C, from anything else. It really completely changed the quality of her life because she could hardly use her hands. And she was a salesperson at a department store in Cincinnati. So doing the machines, right? In those days, you had to use people's credit cards, right? You had to swipe them onto those tabs. She really struggled and wound up having to give up her job because she just couldn't use her hands enough. So, it's impressive when you see it.
Dr. Feinberg, I have to go here in a minute for another 1 o'clock conference, but my question is about how soon any or all of those extrahepatic manifestations might present. Is it something that takes a while for that to show up, or could they be an early presentation? And I guess I'm thinking more, not so much of the lymphoma, but the cutaneous or the arthritic. Yeah,
I will say this, that, Jen, that, in the people I've seen who've had acute Hep C, really, I've never seen anything dramatic in them other than a complaint of fatigue. It's hard, of course, the problem to answer that clearly is it's hard to know how long someone's had chronic Hep C.
True, yeah, true.
So,
like Tammy's case today.
Yeah, you just don't know that. So I would, my supposition is that people have probably had their Hep C for a while before you start to see all these things. But I don't really know an answer because, it's so rare that you can point to when somebody's seroconverted. I don't know, John, do you have any insight into that?
I had the exact same answer. There's a lot of times these extrahepatic manifestations will be present at time of diagnosis, but Lord knows how long they've been incubating. We're probably catching them 20 years into disease. So,
always be on the lookout.
Always been. There's a saying that the level of fibrosis does not necessarily correlate with extrahepatic manifestations. So you can be one of these lucky folks who is going through with their hepatitis C infection and not have hepatic fibrosis, but that chronic high viral load and that chronic immune stimulation can set you up for all sorts of immune-mediated problems and extrahepatic stuff. So you can still get, even though your APRI and FibroSure and elastography look great, you can still get cancer. Not liver cancer, but you can get, lymphoma and make your diabetes worse and have all these kidney manifestations and immunologic stuff. So yeah, but I agree with Dr. Feinberg. I have no idea how quickly technically you could get these things. In general, we think of all the hepatitis and a lot of the dermatologic manifestations, especially the vasculitis, sometimes even during acute episodes. So like when I see a patient with a acute vasculitic picture, we always think of acute hepatitis. So, but I would probably put this
a lot for today.
Yeah.
I've seen more of that, John, with acute Hep B than with acute C. But acute C's, the problem there is that so few people with acute C actually get a diagnosis when they're acutely infected. It's that many people just don't feel that sick. They just, they don't seek medical care. Whereas, if you have acute Hep B, you're miserable. It's kind of hard to have asymptomatic acute Hep B. So those people, I think, by and large, come to part of what our experience is skewed by how people present. And the interesting thing is the patient I took care of with the sausage fingers, who couldn't even bend them, she had been my HIV patient for years when this developed. And she had last injected drugs when she became my patient more than a decade before. So this was really a significant, at least for her, had to be at least 10 years into her Hep C course. And she did have significant fibrosis because she eventually, was transplanted and did great. But yeah, it's just so much you don't know. Always so much you don't know about most things. And that's what COVID-19 is teaching us too, how much we don't know about viral disease. So let me share this with all of you. And John, you'll find this really interesting too. So I'm here in Cincinnati because of this family illness, and I came back to Cincinnati to, be the good doctor family member. And yesterday I got a tour of the ICU at a 600-bed hospital in Cincinnati. Now things here for COVID are a little bit on the waning side. So they actually had like 3 or 4 empty ICU beds in a 38-bed ICU. But John, listen to this. They had people whose T cell damage, now, this is like not just an HIV thing, people whose T helper cell damage was so severe. They had one guy with disseminated histo. They had another person with aspergillosis. They had a third person with cryptococcal disease. I'm like, whoa. And I think in the past week or two, there have been some preprints about that just starting to surface about how there's real T cell damage, probably CD4 cell, T helper cell damage. And, so now there's people, and these are people, by the way, who had been in the hospital for a while. These are all like ECMO, long-term ventilated patients. And it's fascinating because they're starting to, develop AIDS-defining illnesses. The kind of infections that we expect in people whose immune systems are just really damaged. Isn't that interesting?
Dr. It's crazy. That's wild.
It is crazy. I was...
The aspergillosis part, we sometimes will see in a chronic ECMO patient, but not the other stuff, not disseminated histone, crypto, and stuff like that. Were these patients by chance ones that received any significant immunomodulators? These, no. Wow. That's terrifying.
They all got remdesivir. The seriously sick ones who showed up after we knew about dexamethasone got steroids. Now some people are getting convalescent plasma, but they didn't get, they tried the, immune modulators in some patients and really have found no benefit. So they stopped doing it. So much is in COVID anyway is like by the seat of your pants. But I said, this is unreal to see AIDS-defining illnesses like this means that there is really significant immune damage from this virus. And these are all people who are HIV negative, by the way. Isn't that interesting? So folks out in the field, this is how weird COVID can be and how much, right? How much you learn just by living through all this. And I was pretty blown away. I told them they had to write this up right away.
Thank you for sharing that, Dr. Feinberg. That is incredible. Were there any other comments to that or the didactic questions?
You're great. Everyone gets 10 minutes of their life back.
I know, we do still have 10 minutes. If anyone does have any questions or thoughts after the fact, please feel free to email me. I'll make sure to have it addressed and everything. So I wanted to have couple minutes to say a few housekeeping announcements. So our next session will be on August 27th, and Rachel Mitchell will be providing the didactic on drug interactions. And Tammy also has a case lined up for that session as well. So that'll be another great full session to keep an eye out for. I want to give a big thank you to Tammy for the case today, and Dr. Feinberg for that excellent didactic. And thank you, Dr. Gilfus, as well, for those statements on the didactic and answering some of those questions. So thank you all so much for joining. We'll see you guys next time.
Okay. Thank
Thank you.
Thanks, everybody.